So to get started, we're gonna start though with the most recent update in concussion guidelines, which is the SCAT6. And Dr. Jim Yu has been great enough to step up the presentation. Thank you very much, Jim.
Thank you. So I know the initial kind of schedule said it was Dr. Alex Panchella, so sorry, no handsome Italian man here, but I'll try my best to make up for it. And
Right here.
I have it opened up right there. Okay, just have to do it by hand here. So hi everyone, I'm Jim. I work at, I'm a sports doctor working at 2 locations in Toronto. Spend some time at Cleveland Clinic in Midtown and another clinic called Orthopedic Rehab Institute in North York. So to start there, it's not going suddenly. Oh, sorry, give me 1 second here. That's okay. So no disclosures on my end. And today we're going to be talking a bit about the newest edition for the SCAT5, or now the SCAT6. And we're going to start off a little bit with a little bit of background. So this SCAT6 came as a product of the 6th International Conference on Concussions in Sports Medicine in Sport, which is in Amsterdam. And we're going to give a little bit of background about that because a lot of interesting things happened during this conference. So to start with, this is their own kind of summary of the key points they updated. So they made some definition updates. They reported some improved methodology and how they came up with this consensus process. I won't go through all of these today just because it's a bigger topic, but I'll highlight a couple of these. They've changed their return to learn, return to sport strategies. They've incorporated a few things where they think there's strong evidence that a lot of us are already incorporating in our practice, but they're kind of making it official. So, there's strong evidence that, early gentle physical activity and aerobic exercises is recommended. Persistent symptoms should be treated by a multidisciplinary clinic, et cetera, kind of things that, for a lot of sports doctors has been kind of already the standard, but this is now kind of formalized. They do make a note about things like advanced neuroimaging, blood-based biomarkers, things like that. And generally what they're saying is, it's very cool, it's interesting. We don't have enough research yet, but we'll see kind of where it goes. They've updated a lot of tools that you see, like there's this CRT6, which we won't go over today, but that's the concussion recognition tool meant for non-healthcare professionals. The SCAT6, we're talking about the SCAT6 as well. We won't talk about the child SCAT6 today, but just know that's the version for children. So just to start a bit with the definition. So this is a definition we're all familiar with. We've seen the SCAT5 definition. Won't go over all this, but kind of a general overview, a little bit vague. Just because we know concussions, there's no exact diagnostic test that you can confirm. So telling us many different ways can cause it. You can have many different symptoms. Your symptoms can range over a long period of time, but imaging should be normal. And so they had a little vote in terms of how they should approach this, in terms of an updated definition to reflect, emerging research and current evidence. So this is what they've kind of come up with. It's kind of what they call the modified Berlin definition. So interestingly enough, even these experts couldn't come to an agreement in terms of how we should define concussion. They actually had a 78% vote to say use this, but they had said in their initial meeting, we have to hit 80% to be called consensus. So don't be afraid if you don't know how to define concussion. Okay, they can't either. So very similar to what we saw in the Berlin definition, they just kind of slightly changed it, saying, this initiates a neurotransmitter and metabolic cascade with possible axonal injury, blood flow changes, inflammation affecting the brain. Everything else is kind of very similar. Just to give you a little bit of an idea, so the first round they voted 16 out of 28 for this, and then the second round they actually voted 22 out of 28. That's where they got the 78%. But they were debating whether or not they should use this definition. So this is the ACRM definition, which is the American Congress of Rehabilitation Medicine. And they came up with this criteria system, and they have a whole different box with what fits for criteria. So like, is there a plausible mechanism? Is there clinical signs? Is there acute symptoms? Are there any more objective symptoms? Any imaging? And then you kind of tick off boxes and you say, okay, this meets criteria for concussion, mild, moderate, So they were debating whether or not they should kind of unify things, but in the end they decided, you know what, stick to the modified Berlin one. So just to show you guys, this is about, like, this is something we almost came up with. You might see it a bit more down the road, just so you're aware of it, okay? So now to the meat of the talk. What's the difference between all these different things? In their words, this is kind of their main highlights. Now, before I go into it, just to give you a heads up, I'm assuming most of us are familiar with the SCAT5, so I'm not going into too much detail in terms of the actual SCAT itself and how it's done. If you aren't familiar with it, don't worry. You don't have to unlearn and relearn something, so it actually will be much easier for you. But just in case, I'm not going to go into the detail of the SCAT5, but we can go through. I have actually copies of it here if you want to read through it in more detail. So I'll come back to this at the very end. They also were a lot more transparent about the methodology this time, so they actually show you what topics they voted on, what their voting was. They had the ability for people to give a dissenting opinion. They could actually give you a little bit of text. So, for example, one of the dissenting opinions for the definition of concussion was they thought things needed to be much more objective. They think if we're doing a definition, you need to have some sort of objective criteria rather than something that's more subjective. Otherwise, you're going to have a very high false positive, false negative, things like that. That being said, I'm very curious what the person thought would be better, because we don't have a lot of objective kind of criteria. Oh, sorry. Just to break up the morning a little bit here, before we get started, I'm going to go, oops. I want to show a video. What is it? Sorry, give me a second. Wait a second, sir.
Just maybe if you exit out of the presentation and then full screen the video.
Does that show up? Okay, that should. Now this is an incident that actually happened just a couple weeks ago, highlighting. We'll see some faces here, and unfortunately a pretty serious injury. So just to kind of get things started, think about if you were in this situation, what would you be doing, on the field versus off the field, etc.
Player beats him to the wall. Rama sends him a ship harmlessly away, and that is a high-speed collision, scary, and immediately trainers are being waved over. Concern for both, sprawled out, high-speed head, and they're saying get on the field now, get stretchers, and that is the last thing we want to see. And they're saying we need the stretchers now, so football will take a back seat.
Is it a quick replay?
Saying again, they have been incredibly unlucky. When I rate that portion, I think you might be right. So, we're not going to be able to replay these multiple times.
So I'm not going to replay the whole thing, but just going to replay part of it. Just think about, like, if you're on the field, what would you be doing? Take a look at what the trainers are doing, and that will kind of prime us for later in the workshop today too. So this is already after the injury. I just want to see what the therapists are doing.
We want to see, and they're saying we need the stretchers now. So football will take a back seat. And specifically saying again, they have been incredibly unlucky. When I rate that portion, I think you might be right.
Okay, so we won't watch that again. Too much action for Friday morning. If we do that, and okay. All right. Okay, so now we're going to go into the actual kind of SCAT5 versus SCAT6 here. Okay, so on the left here we have our old familiar SCAT5 versus on the right here we're going to have the SCAT6. We're going to go through some of the comparisons here. So just on the first page, the highlights are not actually on the document. That's our added kind of stuff just to highlight it. So first thing you'll notice is the patient information has been removed there. It is now actually combined into a Page 2 is a kind of more of a whole section for athlete demographics, just so you're not flipping back and forth, just filling out demographic information there. Just makes it a little bit more neat and easy to see. They've used some changes in terminology just to be a bit more inclusive. They're saying healthcare professional rather than say things like a licensed physician, or I think the exact wording is licensed physician or licensed healthcare professional, whereas nowadays it just says healthcare professionals. They specifically mentioned a few things, that the time to perform the SCAT6 is no less than 10 to 15 minutes. I like this change because you'll see some of these things they've added on. It is now going to be a little bit more labor intensive. So by having that wording, it really emphasizes, hey, we need that time to do this. Otherwise, we're not going to be able to do a good job. And especially because this is endorsed by so many governing bodies, sport organizations, hopefully it really emphasizes, give us that time we need to do a good job. Otherwise, it's very, very hard to make a good decision on these things, right? Especially when you're under pressure and that kind of stuff. So couple other small things. I don't know if you guys can read there. I think the wording might be a bit too small. I'm sorry. But they have the key point section on the right in SCAT5. They still have that key point section on the right in SCAT6. They just added a couple things here. One thing they've added that's just a separate thing is no athlete diagnosed with concussion should return to play on the day of injury. So that sounds very obvious. It used to be kind of embedded in the middle of a paragraph. They've made that a separate point to really highlight, okay, if you're thinking they have a concussion, do not let them go back. Another interesting thing they've added is in terms of the things they should not be doing. So in the old SCAT5, they said athletes with suspected concussions should not drink alcohol, use recreational drugs, and should not drive a motor vehicle until clear to do so. They've now added a little line here saying that athletes with suspected concussions should not take medications such as aspirin, anti-inflammatory medications, sedatives, or opioids, and then alcohol, recreational drugs. Just to emphasize, hey, if you're suspecting that, don't take anything that could increase the risk of a bleed or anything that may alter their mental status, even if it's like a prescription medication.
Sorry, Tim, let me interrupt for a second.
Yeah.
We'll be quick. It's no small matter. It's diagnosed. Once a diagnosis is made, that day of the injury, you're not going back. What often happens is you have something like this guy on the field where there's some posturing. But imagine they were completely, after that, just a few seconds, they're back, and 10 minutes later, they're saying they have no symptoms at all, zero. They feel great, let me back in. That's a concussion, right? You've got no other diagnosis you could possibly explain what happened on the field, and yet it happens. People will say, "I'm fine, I feel nothing." They do all their SCAT stuff, they're perfect. It's still a concussion. It's not a small issue.
Absolutely, and that's really nice that they actually brought that out to as a separate point, because sometimes when you're just scanning quickly, you kind of gloss over it. As a separate point, it's very clear, it's right in your face. If you're suspecting this, do not let them back in. So I like that little change they did just to emphasize that point. And yeah, great point by Tim there. So we're gonna actually go through some of this stuff in terms of a flow chart that they've added in SCAT6 that will kind of really highlight what you should be doing in a situation like that. I figured just to kind of break up the Friday morning, we can do a little fun trivia at the same time. So just a quick true or false. Woodpeckers obviously are hitting their heads a lot. Woodpeckers cannot get concussions. True or false? Woodpeckers cannot get concussions because their brains are too small. True or false? Show of hands. True? False. Okay. Does anyone know why woodpeckers don't seem to get concussions when they hit their heads all the time? Apparently it's because their hyoid bone and their tongue actually wraps around the back of their head and acts as a shock absorber. Okay, all right, so now that we're awake. Okay, so this is now page 2 of the SCAT6. So this is a separate page. As a side note, for the SCAT5 versus SCAT6, the parts that you're actually filling out have gone from 5 pages to 10 pages. Sounds like a lot, but it's actually a lot of the same stuff, just kind of expanded out in a little bit more detail. So there's a couple of pages that don't have a direct corresponding page, but the general gist of it is the same. So the athlete demographic information has been moved to this centralized kind of page in page 2, and lets you fill everything out. They also added a little bit in terms of the concussion history Most of the questions are the same, like have you been diagnosed in the past for concussions, how many times, etc. They just added one line there saying what were your primary symptoms. So you have something, just a quick kind of glance there. And then the second half of the page here, you're going to see there's this flow chart. This is a new thing. I actually quite like it because it gives you this kind of quick reminder in terms of, okay, I'm dealing with this. What am I going to be needing to look for on the field? Okay, this is specifically on the field portion. And it's not necessarily a baseline thing you'd be doing. So unfortunately, I know the words are very, very small here, but I'll kind of read it out for you. So what you're going to start with is that center bit, red flags. Okay, now the only one comment I'll make on this is it doesn't necessarily tell you it, so you have to keep flicking, like going back and forth between the next page to get the exact details. But once you're familiar with this, like you'll have it all there. You'll just remember, like, okay, this is the flow chart we're going for. So we'll go through red flags. If you have any red flags, easy, answer's done. They need to get further assessment, so they should be removed from play, assessed at an area with a higher level of care. Oftentimes going to be the hospital there. If there's no red flags, then you're going to go down to step 1, which is observable signs, and there's going to be a little section on that. And if no, to the next one, which will be GCS, no issues there. If it's 15, then you can go to the next one, then you go to C-spine, and if that's okay, then you're going to a new thing called the ocular motor visuals testing, which we'll go through, don't worry. Finally, you do your MADOC questions, and then if that's all normal, you can continue with the SCAT6. So the idea is if any of this stuff is abnormal, you should really be considering removing them from play, escalating to a higher level of care so that they can get proper testing and monitoring if needed, or further tests and that kind of stuff. So that's the overview there. We are now going to go, this is kind of their SCAT6 page 3 versus SCAT5's page 2. They've changed things up a little bit here. So on the top right there, you're going to see they're called box 1. That's the red flags. So this is the first thing you're looking for to make sure that there's no major issues. Again, the words are small, but just very similar to before. You know, there's neck pain, tenderness, seizure convulsions, double vision, loss of consciousness, weakness and tingling in more than one limb, deteriorating consciousness, vomiting, severe headaches, etc., etc. That's kind of the same as before. Most of us are familiar with that. It's kind of incorporating, you know, C-spine rules, CT head, and a bunch of other kind of more worrisome factors. So as long as there's no red flags there, then you can go to step 1, which is on the top left of the right-hand part. And then we're looking for observable signs. So they have a new section where you can say if it's witnessed or observed on video. And then they've added a couple of small things here. So a new criteria is falling unprotected to the floor. This wasn't there before. So if you witness that, that's supposed to be a bit of a red flag there, or it's within the observable signs, sorry, not the red flags specifically. They also added something called impact seizure and high risk mechanism based on your sport. So that's a little bit of a subjective thing because you have to know your sport well to know what a high risk injury is and things like that. But they've given you a little bit of leeway there in terms of like, if something doesn't look right, something makes you worried, trust your gut. Okay.
Sorry, Jen. So
yeah.
Just for the concussion workshop, it's going to be videos from a bunch of different sports so that you can essentially start practicing trying to apply those observable signs. And like Dr. Rinsbacher was mentioning, like these things happen for like 5-10 seconds, and if you don't catch them, you've missed it, because they can return to normal in quotation marks pretty quickly and deny any symptoms. But that's why these are so important in terms of the observable signs. Sorry for that.
Yeah, no, exactly. So, and a couple things you'll notice, like for example, in the red flags versus the observable signs, there's a bit of repetition. So, for example, seizures a red flag, impact seizures on the witness observable signs. I think it's just to emphasize there. Sometimes you might not see it right away, right? Because impact seizure just happens for maybe seconds, and by the time you're on the field, you're by their side. They could have been like returned to normal consciousness, and they say, "Oh, I'm fine." But if later on you go to a video or something and you see, "Oh, whoa, he had some seizure activity," or he or she had some seizure-like activity there, you gotta remember that's an observable sign that would be concerning. Okay. So they've also moved, SCAT6 has moved some of the order of these things around. If you're familiar with the SCAT5, we do red flags, and then observable signs, and then we go into MADOC score or MADOC question with the memory assessment, that kind of stuff. They've kind of flipped it around. I prefer this because I think it flows more naturally in terms of what you'd be doing in terms of an emergency assessment. I'm not going to be doing MADOC questions if I'm really worried their GCS is 15. So I think this slight change is just to kind of reflect that flow and what your brain should be doing in the emergency kind of assessment. So they're looking for GCS. We're really looking for a completely normal GCS to continue. If GCS is not 15, you should be a little concerned there. Otherwise, nothing itself has changed in terms of the GCS. Then they ask us to do cervical spine assessment. So back in SCAT5, this was further down the tool. So they've moved that way earlier, which I think again reflects what we should be doing. Most of us are already checking spine much earlier than if we're checking something else like their symptom scores or something like that, which was back in SCAT5. Our cervical sign assessment was way down near the end. They did add a couple of specific things here. So when we're doing the cervical spine assessment, so obviously things like, do they have neck pain at rest, just to reflect our C-spine rules and that kind of stuff? Is there neck pain to palpation? And then can they do active range of motion and strength and sensation normal? Now, they've added a completely new section here called coordination and ocular motor screen, just to reflect a lot of the research saying that a lot of the times with concussions, we have a lot of ocular motor or coordination issues. So some of these tests are completely different. So you'll hopefully see a lot more of these on the field when people are being assessed. So the first one, for example, is a finger to nose. So they ask him to do right hand or each hand 5 times finger to nose. So you put your finger approximately, I believe they said like 60 centimeters in front of them, and you ask them to do finger to nose 5 times each side, and then do the same thing with their eyes closed. So that's a new one, okay? So 5 times eyes open, 5 times eyes open, and then 5 times eyes closed, okay? They also want them to just do a quick side to side, up and down in terms of the eye movements, and make sure they don't have double vision, and then you do a full extraocular movement kind of testing and make sure they don't have any symptoms there. So this is a completely new thing, reflecting some more research saying, ocular motor stuff can be involved in concussions. So I like that. It doesn't take too long, pretty important. I think a lot of people are doing that already in some fashion on the field. So just kind of formalizing that. And then finally, we go to the MADOC questions that we're all familiar with. And this is all technically things that you should be doing on the field to make sure there's nothing worrisome that needs escalation to higher level of care. Okay, and let's do another quick trivia before we continue. So many of you guys are familiar with SCAT1. There's the SCAT, SCAT2, SCAT3. There's no SCAT4, and there's SCAT5, SCAT6. So did you know that SCAT4 doesn't exist because 4 is an unlucky number in Mandarin? It sounds like death, and so they skipped SCAT4. True or false? False. Yeah, sorry, I'm just messing with you guys. They use, if you're curious, it's supposed to correspond with the number of the conferences they're at. So this is the 5th international consensus statement, so SCAT5. This is the 6th consensus statement, so SCAT6. They skipped it at SCAT4 because they didn't change anything. Just making sure you guys are awake. All right. So next page. So back in the SCAT5 on the left, they had that athlete background. That's all moved to that central demographic information portion. Just everything's a little bit more centralized there. The symptom evaluation, that's all, that part hasn't changed there. The main thing is on the right there, they still had it a little section. Part of that athlete background is still there as a reminder of these are the kind of risk factors for prolonged symptoms. So you have a quick reminder there. So you can double check that if they've had any of those issues. One small thing that's changed here is that the instructions you're giving them when you're doing this is different if it's a baseline test versus a post-injury test. So back in the day, we would just say, hey, how are you feeling right now? Fill out the score, and then go from it like that. Versus now they're saying for the baseline testing, ask them to fill it out as if it's a typical day for them. And then for post-injury, we are then saying, okay, how do you feel right now? Fill out the symptoms based on how you're feeling right now. They've also slightly changed it a little bit in the sense that at the very bottom there of the right, they say, you often hand the form to the athlete, they fill out the symptom scores, and they hand it back to you. They have a little reminder there at the bottom of SCAT6 now saying, feel free to explore some of these symptoms if you need. So it's not just, hey, fill it out, let me look at it, and then continue. If someone says, 6 out of 6 headache, something like that, feel free to explore that a little bit. You have a little section there, you can add some notes. Just as a reminder, sometimes you can get more information there, and that's helpful. Okay. So this is the next page for the SCAT5. This is kind of where a lot of the testing that we're doing, the cognitive tests, we have immediate memory, orientation, digits backwards, month into reverse. All of these are still there. Some small variations we'll talk about. We'll break this down into kind of parts just because there's a lot in this one page here. So just to compare, the left-hand part of SCAT5 is on the left, and then this is what the new SCAT6 looks like. So this part has been dedicated to a whole new page there. Orientation there is still the same. However, you'll notice with the immediate memory, there's a big change here. We're no longer doing 5-word lists. Now, 10-word lists are going to be the standard. Back with SCAT5, 10-word lists were an option, but the main problem was we saw a lot of what we call a ceiling effect. So people who were, fairly high ability would get 5 out of 5 each time, and then even in delayed recall, 5 out of 5, even if they were concussed. So the concern was this test might not be challenging enough to really tease things out. So we should use a 10-word list, which is much harder, as you can imagine. You see a lot of people being like, 10 words is like, I couldn't even do that, right? So it's just much harder. I do like that they've made this effect, and we'll talk a bit more about my overall impressions, but my main critique here is while 10-word lists are harder, they don't tell you necessarily what a normative value is. So if you really dive into the research why they chose this, and some of the normative values they've covered in college athletes, I think there's one study looking at like 500 college athletes at baseline. I think the average score after 3 trials of 10 was 10 words was 22, and on average the third trial had a score of 8. And then on average the delayed memory testing was 6.5-ish or something like that. So just to give you a general idea of what their normative values were. But the tricky thing is, if someone scores 25 out of 30, is that they're normal? Is that abnormal for them? It's a bit harder to say, so you might have to rely more on baseline testing or something. Unfortunately, they don't give us much guidance in terms of that. But the idea is, you may have to know your demographic a bit more in terms of what to expect, because a 13-year-old versus a 19-year-old might have different abilities in terms of memorizing 10 words that quickly. The words themselves are all the same. The main thing is that now list A was what used to be the end of the list there. So hopefully people haven't memorized those lists. So it's a bit of a new change in the words. Otherwise, everyone starts to remember, finger, penny, lemons, like it's just default there, right? So giving us a little challenge there. And they still have alternate lists and that kind of stuff if you like. Okay. So then the other half of the SCAT5 there, so we're doing digits backwards, months in reverse, small changes here. The digits backwards, the main thing is that on the instruction piece, they're asking us to do a example to make sure they understand it. So for example, all the instructions are very similar, but near the end they say, so if I said 968, you would say, and they're supposed to say 869, and then you continue with the test to prove that they know what they're doing. Okay, they did have the option to say, if you were worried about the ceiling effect here, you can add 2 more digits, but they didn't actually put that into the final SCAT6, because I personally, in my experience, I find most people are not getting to 7 very easily. But you have the option. If you feel like you're worried someone's very, very smart, very great memory, and you want to challenge them a bit more because you're concerned, you can actually add 2 more digits. Now, for the months in reverse, this is a bigger change. They're now asking us to do it as a timed version, and timing of the test is now an important piece of it. So they want to, the expectation is they should be able to go through that whole thing within 30 seconds, and they want to keep track of it. So actually have a stopwatch open and see how long it takes for them to do it. At the same time, measure how many errors they have. So you're tracking both time and errors, okay? Again, they don't necessarily tell us like what normative values is. They just say less than 30 is what we expect. And it's hard to say, or you're just looking for, I guess, a difference if you have a baseline. This is the SCAT5. That neurological screen there has been removed and kind of broken up into different pieces. So for example, some of the C-spine stuff we're doing way earlier on the field. Some of the other neurological screening in terms of like tandem gait, finger to nose has been kind of changed. So finger to nose is now earlier in the assessment. Tandem gait now we'll see has a whole new section of its own. This part has kind of expanded into several pages. Okay. Some of these, big red, bold, scary letters have been changed a little bit, so it's not going to be as like in your face. It's just a reminder now at the very bottom saying, don't forget, like Dr. Rindesbacher mentioned, the SCAT6 in this case is not a diagnostic tool. They can have a concussion even with a normal SCAT6. Okay. Okay, so just to break that down, so the top there is what the old SCAT5 looked like. It was just a little section there for balance, whereas now we're going into the SCAT6 one part on the bottom. They have a little section here at the bottom of the page that everything is still the same, asking for what foot you're testing, the non-dominant foot, what surface you're testing, what are they wearing, da-da-da. They have a new optional section there saying that you can now test people on foam if you feel like it's too easy for them. Okay, they're still not recommending you wear skates. If people are wearing skates, they should take it off. But you have the option of making it harder if you have access to that, but it's optional. And then it kind of becomes a big piece here. So this is the SCAT6 here, and this is now the new kind of balance gait kind of assessment. So you'll see on the top there, they have the orange piece. That means orange means it's optional. In general, the whole SCAT6, and we'll see later in the SCOT6 as well, anything that's orange is optional, but it's there if you feel like you need it. So the first part, modified best, that's still the same. Double leg, tandem gait, tandem stance, and single leg stance, that's all still the same. However, they've now made the tandem gait, which used to be part of our neurological screen, into a whole section of its own. So they now want you to actually have 3 meters of athletic tape or something as a marker. So this is something that we may need to incorporate more in our exam rooms, make sure we have that space or have a section where you can test this out. And pretty much you want them to go heel toe all the way down 3 meters, turn around, come back, and make sure there's no errors. Okay. So pretty much you're saying the exact instructions you're supposed to give them is, please walk heel to toe quickly to the end of the tape, turn around, and come back as fast as you can without separating your feet or stepping off the line. Okay, and you give them a couple trials, 3 trials, and you average it out, and as well as you keep track of their fastest time. Okay, so this is now a recommended portion, whereas previously they said, can they do a tandem gait? Good, okay, neurological screen is done. Now, this second part here, that's all part of this orange part there. This is, again, optional, but again, they're really trying to avoid ceiling effects here because they really want to tease out those subtle things. They can now, you now have the option of doing this tandem gait while doing a second task, which is serial 7s. Okay, so a lot of people are gonna be like how many of us are probably gonna be able to do that? But the idea is we have some very, very brilliant athletes out there, so don't be afraid to challenge them. Same as before, you give them a chance to practice your serial 7s. So you say like, okay, I'm gonna give you a number, subtract 7, give me a couple of them. So you go like 100, 93, 6, 79, da-da-da. And then once they are familiar with that, you have them do that tandem gait on the tape while doing serial 7s, and you give them a new number. So you say, okay, start with 95, go. And then they're walking and saying, 95, 88, 79, da-da. I got that wrong, 81. So just to say like how, maybe I'm concussed. But if you really want to challenge someone, you have the flexibility to be, to be quite hard on the athletes and, really make them work.
Just a quick comment on the skates. The single leg stance and the tandem stance are impossible, basically, even elite players. So one of the things that we sometimes do is take the backward leg and tuck it behind. So they're still quite unstable, but they're not. It's like a blade they're gonna fall for sure. The single leg stance or the tandem stance. So you have to modify it. Yeah. And sometimes it's not practical to take your skate off.
Exactly.
If you're being careful and this person's not you're not sure they had a concussion yet, it's not really practical to have them take their skates off. So it's another way we can modify it. That's
very true. Their official recommendations is not to on skates, but absolutely there are some logistical challenges, so you can modify there. Great point. Before we continue, we'll get one more kind of random trivia, true or false. So you guys may be familiar with the term dementia pugilistica, which is the old term kind of for CTE. Did you know that pugilistica has the same Latin root as the dog pug? True or false? Sorry, true or false? Pugilistica has the same Latin roots as the dog pug, because pugs are kind of wrinkly and everything, and our brain is a little wrinkly. So that's how that term came to be. True or false?
True.
How many trues? How many falses? Sorry, I'm still messing with you. It's false. Pugilistica is currently the Latin word for boxer, so dementia in boxers. Okay, so finally, we're getting close to the end here. We have delayed recall. So after all that testing, we're rechecking their memory. One nice kind of quality of life improvement they made for us is that we have the words there again, so you don't have to go back and refer to it, because we all know by ourselves we often forget those words, especially 10 words. I don't think I would ever remember that. So they have it right there for you. They have like a 0 and 1, so you can easily keep track of which words have been said and that kind of stuff. Sorry, I forgot to mention that's also in the immediate recall as well. Just like small quality of life things just to make it easier, so you don't have to memorize it yourself. And sometimes they repeat their own words. You're not sure, like, wait, did they say that? Da, da, da. So it's just easier for you to keep track of it like this. Finally, at the end there, they have a total cognitive score, just a little quick summary that you can write down the numbers. So you can kind of quickly refer to this. So like I mentioned earlier, SCAT5 was 5 pages in terms of the fillable content. Now it's 10 pages. You can see overall a lot of the same stuff, but it's just been expanded out a little bit easier for us to follow. It is just more pages though. Final page, this is the kind of the summary page. So SCAT5 on the left there, they have this kind of summary for score and then decision, things like that. Now on the SCAT6 on the right there, overall very similar. Main difference is, again, that emphasis on the scoring on the SCAT5 should not be used as a standalone diagnostic tool. That's kind of just a small little kind of asterisk at the very end there. I think they feel like they've emphasized that point enough. So it doesn't have to be as big of a topic there. Finally, in SCAT5 at the very end there, you guys might be familiar, you have these like information you can hand to the athlete, return to sport, return to learn, that kind of stuff, guidelines. This is now a separate piece for the SCAT6. I guess they thought there's too many pages already. So they have a supplemental thing that you can download and print off for people that has this stuff still there. I will highlight some of the changes, but like the instructions and that kind of stuff are on a separate document now if you're looking for it, okay? So biggest thing in terms of the return to sport, I'm not going to go into too much detail here just for time's sake, but the big thing is return to sport. They're using a lot of heart rate things to guide us. So for example, when we're talking about light aerobic activity versus moderate aerobic activity, they're now recommending it based on your max heart rate. So light would be 55% of your max heart rate, and that's just based off 220 minus age. And then moderate activity would be 70% max heart rate. So they're kind of giving us a little bit more objective criteria you can use. A lot of us were already using heart rates to guide us when we're returning to activities. They're just kind of incorporating that as this is a very reasonable way to do that. They do comment in terms of at the activity on each step. They say they are okay with mild and brief exacerbations of symptoms. And then they have a whole little tidbit there. Mild and brief means that on a 10-point scale, it is no more than 2 points worse for more than an hour. Now, I'll be honest, I found it a little weird because we've been using 1 to 6 scales so much for the symptoms, and suddenly we're using a 1 to 10 scale. I thought that was a little bit unusual, but the idea is it should be a very brief and small increase. And then they have a note here saying if you're going on to step 4 to 6, they really should have no symptoms at this point, no abnormalities in cognitive function, and no other clinical findings to make you concerned that the concussion is still significantly ongoing and you're letting them return to something more intense. Return to school overall, nothing's changed too much there. Again, they just have that small note saying mild and brief exacerbations are okay. So going back to that little summary page that we had at the very beginning there. So just to kind of put that all together. So they changed the demographic sections a little bit there. That's all in one little page there, a little bit neater, a little bit easier for us to follow instead of going back and forth just to fill out different parts of the demographics. They do have a little line there commenting the SCAT6 is used for adolescents, so 12 and above, versus the child SCAT6 would be used for younger. That's unchanged. SCAT5 had the same wording, but there is a mention that the SCAT6, which we'll talk about very briefly here, is to be used if it's more than 3 days. And then they've also commented the SCAT6 takes at least 10 to 15 minutes, so take your time. Hopefully this will put some pressure on the governing bodies to give us that time. I'm sorry, I skipped ahead there. So SCAT6 is to be used within 3 days and up to 7 days, but if it's in the office setting or after 7 days, you should be using the SCAT6. They've changed a few of the, like just in terms of the instructions and general information there. They have this new flow chart which includes the neurological screening, the ocular motor coordination screening. Those are new things that we're going to practice today. They've had this enhanced red flag sections, small changes in terms of witnessed or observable signs, things like that. Slight change in terms of the instructions when they're filling out their symptoms, if it's baseline versus post-injury. Big ones here, 5-word list is gone. We are now only going to be using 10-word lists. We have timed components to the months in reverse. We have more coordination and balance testing. That part has been expanded quite a bit. And then we have some optional ways to make it harder as well. And then just some small changes in terms of how they give some instructions and that kind of stuff. Okay, so a couple things I wanted to highlight there. Generally speaking, I like a lot of the changes that SCAT6 has made for us. I do think a lot of the things flow a bit more easily, just in terms of how they've visually broken up sections, color-coded things. Instructions are now in blue italics. Everything just flows a little bit more easily versus previously everything was just a big wall of text. It could be a little overwhelming sometimes. It's a little easy. The formatting has definitely helped a lot. The instructions being a little bit more clear and things broken up a little bit makes it definitely easier to administrate, although there's some nuances there in terms of like now we need tape, a stopwatch, so just some small changes there. They've really done a great job in terms of removing any potential for a ceiling effect. Okay. They've also definitely highlighted how ocular motor symptoms, which we know are a big part of things, that's kind of now formalized into the SCAT6. They have a nice summary page that allows you to keep track of things, and hopefully this will influence sport organizations to give some more time. So those are some things I really like about it. However, some areas for improvement, they didn't necessarily give us the best rationale, so you had to really dig to find why they did some of these things. It definitely is going to take longer. There is a little bit more of that administrative burden there. The fact that now the ceiling effect is removed does give us a little bit more uncertainty in terms of what should we expect there. So I feel like we're going to need more and more baseline testing for these kind of situations. They do specifically make a comment on VOMs, so the visual ocular motor screening. They emphasize the importance of the ocular motor symptoms. They have that section, but they 0 out of 28 voted to include the VOMs in the SCAT6. Probably, I think, just because of timing. But interesting enough, I think it was 19 out of 28 said to make it optional, but they didn't make it into the final edition of the SCAT6. But you'll see in the SCAT6, it did make its way there. Lastly, in my opinion, some of those optional things they mentioned, like the dual task tandem gait, is very hard. I'll be honest, I don't see myself doing that very often. Some of the other ones, like doing balance testing on foam, it's great that they have there as an option, as a reminder. I'll be honest, I don't see myself doing that very often unless these people are very, very high performing, and I'm really trying to tease out something subtle. But the more of these things you do, hopefully we'll improve our kind of natural flow of things, and hopefully we'll be more efficient at it. Quick 2-minute kind of overview, because they've added this thing called the SCAT6, which might be the new goat of all tests. I'm just going to go over it really quickly. So this is the sport concussion office assessment tool. So the idea is if it's been more than 3 days where you're in the office setting, this is their preferred way of testing for things. A lot of it is the same. The instructions are still the same. The formatting, everything is very similar. I'm just going to go through very quickly. So you have a section here that you can do for background information. You can take your history through this. It has you can a lot of checkboxes just to kind of make things flow more easily. So the idea is hopefully if you have an EMR, you can just integrate this into your EMR, just fill it out through that. And then you have history of head injuries, history of any neurological issues, list of medications, family history, and then you go to the symptom score. That's all the same, but they have multiple sections here so you can keep track of it over time, so you can keep filling out the same form. They have this part's all the same. Then they do the immediate memory. That's all still the same as the SCAT6. They have the option here to even do 15-word list if you want. I don't see myself doing that very often. Digits backwards, that's all still the same as the SCAT6. Months in reverse, same. It's also timed components. And then here's where I think it might get a little controversial. They now recommend us do orthostatic vital signs. So the problem is that can take a bit of time. They want us to make sure they're supine for 2 minutes, take a blood pressure, stand up for a minute, and then, or stand up, and then 1 minute later take another set of vitals, because they're saying there's some weak or some kind of evidence. More research is still needed, but they are seeing that in concussions we can see some of that heart rate variability and orthostatic kind of changes. For adults, it's supposed to be 30 beats per minute or more. For pediatrics, it's 40 beats or more. But my main concern is this would add a lot of time to our assessments. We already know how little time we have in clinic and how long concussion assessments can take. But their thoughts are that getting blood pressure and vitals is part of any good assessment. Just take a little bit more time, do the orthostatic vitals. You might catch something a little bit there. Then we're going through your C-spine assessments, neurological exam, the balance testing, everything there is still the same. Time tandem gait is still the same, and you have extra things that you can do here as well. So you can do a complex tandem gait where they're doing steps and then closing their eyes and taking more steps. So you ask them to do 5 steps, eyes open, 5 steps, eyes closed, turn around, come back, do the same thing. You have the option of the dual task gait as well. So doing serial 7s while doing the tandem gait. And then finally here they have VOMs, so you can, or the modified VOMs. They've just taken the pieces of it. I won't go into details of VOMs, but you're just testing for ocular motor symptoms, right? I like parts of this where they now have built into this form anxiety screens, depression screens, and the PHQ-9 GAT7 is all there already, so you don't have to print out another page and add it on top and check everything off. It's all built into this. So this document kind of incorporates a bunch of stuff that we might be doing. And again, it's optional, so it's not like you have to do it for everyone. And then sleep screen as well, because we know that can be very important as well. And then finally, we do delayed recall. Now, my main comment for here is we know delayed recall, you're supposed to wait minimum 5 minutes. I think if you're doing all these things, is there a point that you would be waiting too long? Well, they don't clarify that. They again have some more optional sections here. If you're doing any computerized testing, like an impact or something like that, you have an option there to kind of check on, say, okay, we did impact, this is the results. If you did a graded aerobic exercise test, like the Buffalo, concussion, treadmill, or bicycle kind of system, you have the option to kind of keep track of that as well. Okay, and then final kind of plan and summary, and then they have a return to learn, return to support all there as well, and that's it. Okay, last trivia piece, true or false, the Buffalo concussion protocol was created as an estimate if you could run away from a buffalo in time.
No.
True? False? Okay, yeah. Okay. I've trained you guys up. Okay, all right. Let me know if you have any questions.
How practical do you think that SCAT6 is? On a scale of 1 to 10, 10 being the most practical thing. Nobody here is.
I'll be honest. I think it's a little. Some parts are less practical, but I do like the fact that they've incorporated some that flow chart in terms of the on-field assessment. I actually think that's a better system than what we had before. But some of the other stuff in terms of the tandem gates, some of those things I feel might be a little frustrating for some of us, knowing that we need this extra equipment, we need this extra space, and it's just adding a few steps. So some parts there might not be ideal, but there's some sound reasoning behind it. It's just a matter of how practical it is in our current medical system. And it's more of a knock on the medical system rather than it is, I think, on the SCAT6. So, yeah.
Which would you use as a baseline? Because this code has a lot of anxiety, depression.
Yeah, so that the SCOT is more for. You can theoretically use it for baseline. They do have a section there if you want to, but generally speaking, you can use either, because most of the times if you're doing baseline testing, because they overlap, they have the same test for most of it. The on-field assessment for SCAT6 is not relevant in those cases. All the tests there are pretty much the same, so you could really use either. But if you're using the SCOT6, you probably wouldn't be doing all of those pages. Like you wouldn't necessarily have to do a depression screen or anxiety screen for all of them. You just pick and choose the parts that you think are more relevant, which is the recommended sections usually. Yeah. Okay. Any other questions? If you guys are curious, I do have the SCAT5, SCAT6 printed out if you want to just look at it and just see kind of how it visually looks on a page. If you guys are curious, you can just grab it over here. it's
Let's pass it around.
Sure, get back
Yeah.
here.